before. I was diagnosed with diabetes 9 years ago, so I was 41. The one thing that I have got is I've got severe neuropathy, where I've got no feeling in my feet at all. But I never actually realised what was involved in being a diabetic and how serious it was until much later in life. Nothing really happens until we went on holiday. We was in Egypt, we were out on the beach and I walked on some glass. I'd burnt my feet as well on the sand without realising. The glass went in so deep, it infected all the bones in my feet. And I also had burns to the feet as well, which started the ulcers on both feet. This one cleared, this one didn't. We occasionally did get a bit of an odour if it wasn't going quite well. If I had that, I wouldn't go out. If we had people coming round, I'd certainly make sure it was covered up and everything was sort of as fresh as I could possibly make things smell. Sometimes I would wake up and time to have a dressing and I'll be a bit worried on what I was going to see. It really did start to make me panic a bit and get a bit worried because you can see yourself diminishing. We tried different dressings, but it would never quite close up. And obviously the problem is the infection that was there was just constantly wearing it down. The worrying thing was, well, if the infection's there, where is it going to go? How far is it going to spread? What's going to happen? It really hit home that I think I thought it was going to change my life, which it did. There's been a couple of days where it's got to hating the world, hating myself, hating everything. And then what you do put upon the family, you know, their lives all stop to help you 24 hours a day. It's not fair sometimes. For me, it is what it is now. I'm 50 years of age and I'm alive. As long as I can take a breath of a morning and I see my grandkids and I see Jade and all that thing, that is all that matters now.
I like starting the session with this video because it gives us everything we need to know basically about diabetic foot. The lack of awareness of the patient who went walking barefoot on a beach, the anguish, the trouble, the worry about getting an ulcer, how it involves the family, how it depresses the patient. So understanding from a patient's point of view brings what we are going to say today a lot more in perspective, because we look at the statistics. The statistics are staggering. The amount of patients with diabetes out there is massive. The amount of patients getting diabetic feet ulcers and ending up with amputations is huge. And one of the most worrying things is that half of the patients don't even know they have diabetes until it's too late and it affects their life like it affected Mark's life. If you look at statistics all over the world, this comes from Australia, but it's the same thing all over. Diabetic foot, the amputations behind it is one of the top causes of disability in the world, which brings us to a first question. How long does it take for somebody in the world to have an amputation? because of diabetes? Is it 20 seconds, 20 minutes, or 20 hours? You can join us in answering the questions, please. Give you a few more seconds. Okay, it's interesting to see that most of you thought that probably 20 seconds is a bit too short, but the unfortunate answer to that is that an amputation directly linked with diabetes occurs every 20 seconds somewhere in the world. The issues behind it is that there's a lot of problems out there, but the biggest unfortunate thing is that 85% of these amputations can be avoided, and we'll see how that can happen as well. First of all, when we're talking about diabetic feet and their complications, we haven't started talking about this yesterday. One of the first associations between diabetes and diabetic foot was even before the 1900s. And we've been talking about the standard of care of sharp depth riding and offloading and education for more than 100 years. And even we had the first clinic that was specific for diabetic foot complications in 1928. So let's start understanding what a diabetic foot ulcer is. So a diabetic foot ulcer can happen because of different things, and we'll see that later on. But basically, all we're saying here is that something like an infection, ulceration, or destruction of tissues in the feet with patients living with diabetes, and it's accompanied by neuropathy, what we've heard Mark talk about, and peripheral arterial disease. And the unfortunate thing about it is the recurrence. We have patients that we struggle to heal. They go back in the community. They get problems again because they don't take care of their feet properly. And the problem here is the lack of recognition of the issues, the lack of knowledge from not just the patients, but also healthcare professionals who don't manage these patients properly. Brings us to another interesting poll. Do you think that patients, the 5-year mortality rate is worse in breast cancer than diabetic foot ulcers or amputations? You have about 5 more seconds. Okay, there's a mix of answers here, and the thing about it is that unfortunately many people are aware of breast cancers, but they're not aware about the problems with diabetic feet. And if you look at this graph that comes out from a publication from David Armstrong and his colleagues, you don't need a major amputation. Even just a minor amputation makes it worse than all cancers put together. Maybe just lung cancer is more devastating.
Shaking a bit. Don't worry.
If you can mute, please. Thank you. So basically, the awareness of diabetic feet and their complications are very devastating, and we need to make people aware of it. So as from these publications from David Armstrong, who's one of the biggest ambassadors about diabetic feet, is that they have to be treated like a cancer. Most of them are recurrent. So are we talking about patients who heal, or are we talking about patients who are in remission? And this is the awareness that we need to think about. But when you look at statistics from publications, if we look, for example, about general practitioners in Europe, they're not really aware of how to manage a diabetic foot. And this is the same everywhere in the world. Many patients with a diabetic foot ulcer will go to an emergency unit or to a polyclinic, and there's no specialist there. So that training is not being given. And one of the most important aspects that we see here, how we can reduce that 85%, is basically looking at late referrals. These patients are not being referred to specialists. We've got people who go to the emergency unit with some abdominal pain, and they get referred, for example, to the gynecology. But a patient comes in with a diabetic foot, and people start playing around with dressings, thinking that they are doing something which is correct. So this is an idea of the standard of care for a diabetic patient. But one of the most important things is that timely referral. If we don't refer to specialists, these patients will keep on losing their feet. And this has been brought to us in quite a few publications, but this publication from Chris Mano et al. From the UK with his European colleagues, we're talking about the late referral, that most of these patients are not referred properly. And the idea of how many healthcare professionals not being aware how to properly treat these patients. And the way how to do that is something that we have been talking about many years here. And this is from the IDF, the International Diabetes Federation, where patients should be seen, whatever their age, whatever their disease, if they never had any problems, at least once a year by a diabetic foot specialist. And according to the risk category, they need to be seen even more often. But the thing is, think about somebody you know who is diabetic. Have they ever been to a diabetic foot specialist? And this is not just from the IDF. We have also the DFoot International, who are suggesting that these patients need to be followed up immediately. We had a huge amount of increase in the past few years, even because of COVID, from diabetic foot infections leading to diabetic foot amputation. So do yourself a favor, do your country a favor. Make sure that diabetic patients are aware that they need to be seen at a diabetic foot clinic at least once a year, even if they had never had any problems, even if they're still quite young. If you remember, Mark in the video lost his leg when he was 50 years old, which is not that old. And we know from Marco Meloni and his colleagues the effectiveness of a fast-track pathway and how important it is to refer, because when patients are not referred, the cases are a lot more severe. It is far more difficult to manage, and many patients end up with an amputation. The early referral and late referral groups, you see a huge difference in the amputations. Why? Because the patients are aware of the problems, and not just that, they know that once they have a problem, they don't go to any doctor or physician, ER or polyclinic, they go straight to the clinic that deals with diabetic foot ulcers, and they get the care which is necessary. There are also resources out there for your patients. You can give this, for example, website link to your patients, which is called SaveFeetSaveLives.com. And there's a lot of tools out there for awareness of our patients as well, because once the patient is aware and his family is aware of the problems that they might face, they can definitely take care of themselves in a better way. Making sure that there is enough education out there. Again, highlighting that education and awareness is not just for the patients and their family. It's even more important that healthcare professionals like yourselves have got this information so that we can manage these patients a lot better. This is another example that comes from the UK, from Professor Michael Edmonds from the Royal College, where they start talking about ACT now. It's a good acronym, but the basics of acting now, not leaving it later, making sure that we are taking care of these patients in a very timely fashion. And always remember to treat your patients with diabetic foot ulcers as VIPs. Look at their vascular status. Do they have enough circulation in their feet? Is there any infection, or is there any residual inflammation that makes the wound even more difficult to heal? Do we know if there's excessive pressure? We'll explain this later on. And what is the status of their productive sensation in their feet to make sure that they know if there is any damage on their foot? So, quick question here. What do you think is the most common type of DFU? Neuropathic, ischemic, or neuroischemic? Okay, we'll give you just a few more seconds. So this is actually a very interesting question, because we have changed our mentality of what we think about, because just a few years back, we always thought that neuropathy is the main problem. But nowadays, we're talking about neuroischemic, and you speak to some vascular surgeons and they will tell you that if not all, almost all diabetic patients will have the influence of ischemia in their feet as well. So understanding the pathophysiology of the diabetic foot, and we'll go through these together to try to understand a little bit more. One thing you might have heard of is classifications, and probably one of the most common classifications which are used is the Wagner, which is quite an outdated classification. We have the IWGDF guidelines that come out every 4 years. Anybody who takes care of diabetic patients should know these guidelines. And basically what they're saying is they're suggesting the newer type of classifications like the SIMBAT, the IFI, and the IWGDF classifications as the ones that should be used, but never to give out a prognosis. So let's start looking at what the IWGDF tells us about identifying a foot at risk. How should we go on to do that? So first of all, we need to do a proper screening. And in order to do a proper screening, we need to be specialists. We can't just check the feet. Yes, it can be done as an early intervention, as we'll see later on, but making sure that the patient is having the routine foot screening at least once a year by a diabetic foot specialist. The medical history that we look at in our DFU patients or patients who are at risk of diabetic foot ulcers is quite different, very specialized, and we need to have a proper list of what type of history that we can conduct. We'll look quite more deeply into the aspect of assessing the diabetic foot. But remember, the shoes of a diabetic patient are part of his feet, and they need to be looked into very closely as well. And whatever education we are giving, we need to make sure that the education is correct, it is updated, and not just give a leaflet to a patient and his family, but make sure that they understand it. So let's do a quick overview of how we can manage a patient that comes to us who is a diabetic patient, again, does not replace the referral to the diabetic foot specialist, but basically this is what they would do as well. So one of the first problems that we see is peripheral arterial disease. So in peripheral arterial disease, we're not just talking about diabetic patients. Everybody can have angiopathy. However, because of the disease process, these patients are more prone to get calcification, which is specific for diabetic patients, but also macroangiopathy, which occludes the main arteries, and more importantly, the microangiopathy that occludes the arteries in the peripheries, which can lead to a gangrene.
Diabetic peripheral arterial disease, PAD, is an occlusive arterial disease affecting distal vessels below the knee. The pathophysiology of PAD can be attributed to structural and functional atherogenic changes to the vasculature. Diabetes augments the process of atherosclerosis by a variety of mechanisms. Two key components in diabetes, hyperglycemia and insulin resistance, contribute to endothelial dysfunction by decreasing nitric oxide bioavailability and altering the function of various cell mediators. Oxidative stress subsequently promotes the formation of foam cells and fatty streaks. In addition, vascular smooth muscle cells exhibit enhanced migration to newly formed lesions, further augmenting plaque development. In advanced atherosclerosis, patients with diabetes have less smooth muscle in the lesions and are more susceptible to plaque rupture compared with the early stages of atherosclerosis. Furthermore, increased platelet aggregation and impaired fibrinolysis also increase the risk of thrombosis, leaving the patient at high risk for complications. Failure to identify and prevent PAD at an early stage can ultimately result in symptoms of intermittent claudication, critical limb ischemia, and lower extremity amputation.
Quick question to see if you are aware of the arteries in the foot. Which are the most important foot pulses that we need to check? Dorsalis pedis, toe arteries, posterior tibial, or A and C? Okay, so the majority of those who answered the poll got it right, which is the dorsalis pedis and posterior tibial artery, which are the most important arteries in the foot. We can start off by the top of the leg by going also and checking the popliteal artery, which is behind the knee. But if we're checking the feet, it's the dorsalis pedis and the posterior tibial arteries.
Hey everyone, it's Sarah, registered nurse, RN.com, and today I want to demonstrate how to find the dorsalis pedis and posterior tibial pulse points. And whenever you're assessing the pulse, you will be looking at a few things. One thing will be the rate, how fast is it, along with the strength, and you'll be grading it on a scale 0 to 3, with 0 being absent, 1 plus it's weak, 2 plus it's normal, and 3 plus it's bounding. And then you'll want to look at the rhythm. Is it regular or irregular? And as you feel on the pulse, you will be feeling bilaterally to see if they're equal. Now we're going to find the posterior tibial and the dorsalis pedis. And these sites are assessed during your head to toe assessment, especially if your patient might have peripheral vascular disease, or if they've had a vascular procedure like a heart cath where they access the femoral artery. We'll always be checking the pulses in these lower extremities. Now the dorsalis pedis, I'm going to turn the foot a little bit this way, is found here. And in order to find that, what you can do is find the EHL tendon, the extensor hallucis longus tendon, that actually helps extend this big toe. So if you lift your toe up for me, you can see that tendon right in here. Now, just follow that tendon and then just go a little bit to the end of it, and that will be your dorsalis pedis. Then we'll find the posterior tibial, and this is found on the inside of the ankle, found between the back of the medial malleolus, which is the bony prominence of the ankle bone, and the Achilles tendon. So you'll find it within this area right here. Okay.
So it's very important to do this pulse palpation. However, very importantly, remember that having a good pulse in the main arteries doesn't rule out problems with peripheral disease. If we find the pulses, there still can be microangiopathy. So it is always indicated that these patients go for further examinations. For example, one of the mostly used in diabetic patients is the toe brachial pressure index. And we'll talk about also the ABPI later on. The second thing that we need to be aware of is neuropathy. So neuropathy doesn't just affect the feet of the patient, it can have a lot of other problems, but we're obviously going to concentrate more about how neuropathy can affect the diabetic foot. So what is happening here is, again, because of the disease process, the nerves become damaged, and then we will start having problems. One of the most common problems that we find, and what most people are aware of, is sensory neuropathy, where these patients get a loss of that protective sensation. So the patients, if you remember, Mark talked to us about going on a beach, burning his feet and getting glass up into his foot without even knowing. And this is very, very dangerous because we have patients walking around barefoot or walking around with inappropriate footwear. So what happens here is that they get a lesion. They don't realize it until it is too late. The other type of neuropathy is motor neuropathy. So we have the motor nerves that control our muscles, which controls our movement, which controls our gait. And what happens is that when there is an imbalance in the muscle movement of the legs, we get pressure in specific areas of the feet, which can cause a callus and hematoma, which will end up as an ulcer. One of the least known is autonomic neuropathy. So autonomic nerves control the functions of the sebaceous glands, and when there is autonomic neuropathy disease, the feet become very dry, they can become cracked. This is why we should always tell the patients to use neutral moisturizers on their feet. And what is happening here is that the patients will get fissures. Once there are fissures, microorganisms migrate into these fissures, they cause infections, abscesses, and ulcers. So if we're talking about loss of protective sensations, usually there are some tests we can do on the feet, which can indicate if the patient has got neuropathy or not. We're talking about sensory here. So do you think we can use a needle or something else like a toothpick to check the patient's feet for neuropathy? Give you a few more seconds. Okay, so it's very important to know the answer of this poll, because one should never, ever use anything to check neuropathy or check the feet of the patient with something that can cause even a micro wound and defeat because it's very, very dangerous and you're not doing it in the correct way. There are a few methods out there. The most commonly used is by means of using the 10-gram monofilament. Over here, we have an image which shows quite a few points on the feet. Actually, nowadays, the IWGDF tells us that if we just check 3 points, it is more than enough to give us an indication if the patient has got sensory neuropathy.
This is Dr. Lanceris from 360woundcare.com, and today I'm going to be demonstrating the Weinstein monofilament testing for loss of protective sensation in the diabetic foot. The monofilament test is performed with a standardized monofilament. The ideal is to use a disposable monofilament, as a reusable monofilament can expose the patient to infection, and over time the filament will wear out, leading to less reproducible results. As you see on the model here, there are 10 positions that are demonstrated for ideal testing for the monofilament test. There's 9 on the plantar surface of the foot, and there's 1 on the dorsal surface of the foot at the web space between the first and second toes. The test is very easy to perform, relatively inexpensive. Some of the things you want to watch out for when you're performing the test is to avoid areas that are obviously ulcerated or have heavy accumulation of callus. Try to find alternative sites if possible. A positive test is signified by greater than 4 out of the 10 points being insensate. The test is simply performed by taking the monofilament and pressing it against the skin until it just begins to bend. Ideally, you'll want the patient to demonstrate a yes or a no if they feel the sensation. Some tips and tricks is to vary the rhythm at which you perform the test, as some patients will get familiar with the rhythm. So you want to vary how often you're pressing, and you also want to alternate sites, not using consecutive sites. This adds a little bit of randomness to the test and helps the test to be a little bit more accurate. It's very important to apply even and equal pressure to the monofilament when it's in contact with the foot. Ideally, you want to just push until you see the monofilament bending. That's all the pressure that you need.
The other test, which is not that popular, unfortunately, but it is considered sometimes even better than the monofilament, is by means of using a tuning fork.
This is Dr. Lanceris from 360woundcare.com, and today I'm going to demonstrate the tuning fork test. This test is performed with a 128 Hz tuning fork. The tuning fork test is another simple, inexpensive test that we can use for loss of protective sensation when examining the diabetic foot. It's a very simple test. This tuning fork typically costs about $3 or $4. The test is very sensitive, and it's actually a little bit more sensitive than a monofilament test when looking for early loss of protective sensation. Vibration sensation tends to be one of the first sensations that's lost. So this is the ideal test for picking up on neuropathy that sometimes is missed by monofilament testing. Vibration sensation, when it's lost, can also be an indicator not only of diabetic peripheral neuropathy, but it could also be an indicator of alcoholism, posterior column disease, syphilis, and vitamin B12 deficiency. So these should be in the differential diagnosis when you're looking at this test. The test is very easy to perform. What you want to do is start vibrating the tuning fork by hitting it against the palm of your hand, hard enough that it vibrates on its own for about 30 to 40 seconds at a time. You don't want to hit it much harder than that. Before you start the test, you want the patient to understand the sensation of vibration. And what we'll typically do with this is apply it either to the sternum. This can also be applied on the arm, just so that they understand what the vibration feels like. What we'll then do is we'll start the tuning fork and then place it at a bony prominence in the foot, typically down here right below the base of the toenails, the most common place we'll start with. And what we'll first do is ask the patient to notice if they're experiencing any vibration, and then stop the tuning fork, suppressing the vibration, and ask the patient to identify if they've noticed the vibration stop. What you want to do, obviously, is to have the patient have their eyes closed so they don't see what's happening with the test. If you find loss of vibration sensation at this particular point, then the next thing you can do is move up the foot, going on the dorsal surface of the foot, the malleolus, and as high up as the patella if necessary. This is a very effective, reproducible, and very cost-effective and inexpensive test to perform to assess a patient for diabetic peripheral neuropathy.
So there are also other tests like heat and cold, and nowadays we have electronic gadgets that can do the vibration and all the other tests together. But one thing that has come out as well is the empowerment of our patients. So the Ipswich touch test has been developed to empower the patients and their families to do the tests at home as well.
Hello, I'm Kumar. I'm going to show you how to test for sensitivity of your feet. It's really important that you check your feet if you've got diabetes.
I'm Alex and I'll be helping Kumar check his feet.
High blood sugar levels can damage the blood vessels and stop the nerves from working properly.
This may stop your feet from healing properly. If you don't feel an injury, you may not realize you have to treat it, which can cause serious problems. In the worst case, it may lead to an amputation.
The point of the test is to check to see if you've lost any sensation or feeling in your feet.
Along with going to your foot care appointment each year and getting in the habit of checking your feet daily, the test is a vital part of your foot care.
Before we get started, ask your helper to watch the video too. Once you're ready, you need to take your shoes and socks off and get comfortable and either lie down on a bed or sofa and then close your eyes until the test is over.
The first thing I need to do is to remind him which is his right leg and which is his left leg. I do this by firmly touching the leg and saying, this is your right leg and this is your left leg. Then I will need to touch the tip of 6 toes using my index finger. This should be no longer than a second and as light as a feather. It's important to keep the order that you touch the toes the same. This would be big toe right, little toe right, big toe left, little toe left, middle toe right, middle toe left. It is important that you touch the toe only once in order to make the test accurate.
All you need to do is keep your eyes closed and say whether the toe being touched is on your left foot or your right foot. Left. Left.
I need to write down a yes if he's correct and a no if he's wrong.
So as we said, there are other tests that can be done, but I guess you understand that the importance is to have it done in a systematic way to make sure that we are providing the correct results. The third part of the diabetic foot assessment is looking at any deformities. Like everybody can have these type of deformities that you see here. However, for diabetic patients, these pressure points are very dangerous because they can cause ulceration because of that continuous pressure and rubbing against the shoe. So these are situations where they can be corrected surgically. If not, at least we can use gel pads to cushion them, and obviously always make sure that we look at these points to make sure that there are no issues. One problem that diabetic patients get when they have neuropathies is a Charcot foot. Basically, a Charcot foot is a fracture of the foot. It doesn't only appear in the arch, but that is the most commonplace. It can happen because of repeated minor traumas, because the patients don't have the protective sensation, they don't realize that. It can happen also because the motor neuropathy, and it's causing pressure. And obviously, the heavier the patients are, the more prone they would be. Remember also that the diabetes disease also can degenerate the bone and make it more fragile, and therefore these fractures can happen. The biggest problem here is that the early identification is usually misdiagnosed, because if you look at that picture at your top right-hand corner, it looks very similar to a cellulitis. These patients are many times discharged on antibiotics. The rule of thumb is that any diabetic patients who comes to us with a red foot needs to have specialized doctors looking at x-rays to make sure that we identify if there are any microfractures, which is the charcoal foot. And as we said, the most common area is the middle of the foot, where we have the transmetatarsal joints and the arch of the foot, but it can happen anywhere in the foot. And that is why when we take an x-ray of the foot, if we are thinking about diagnosis a charcoal foot, we need to identify this with the radiologist and the radiographer to make sure that they are looking for what we are thinking about. And as we said previously, the shoes of the patients are part of the diabetic foot. Make sure that these shoes are proper shoes. Doesn't need to be specialized diabetic foot, but at least they need to be safe. We know that unfortunately in many areas we have patients walking around with these tongue type of flip-flops, which are really dangerous because they don't protect the foot and they actually cause pressure between the toes. Even inside the house, patients should not be walking barefoot. We can assign shoes for the house, so therefore the dirt or whatever we have from the outside is not brought into the house. And make sure that when we are looking at the patient's feet, look at these little tiny hematomas, those little red marks, or a very small blister, which can anticipate a problem. Remember that many of diabetic foot ulcers start off as pressure injuries. So if you look at those pictures, they look like the different stages of pressure injury. So having a knowledge of that also does help. So we've been talking about doing a foot assessment. Do you think it takes really long? Can we do it maybe in 1 or 3 minutes, or can it take even up to 10 minutes or more? Give you about 10 more seconds. Okay, so most of you said 3 minutes, and that is partially correct, because in order to do a test for both feet, it does take about 3 minutes. And remember, this is just an initial test to look over. So this is the in-laws 60-second diabetic foot screening that just takes about 1 minute per foot.
Simplified 2012 60-second. Have you had a previous ulcer?
No,
Amputation?
no,
On exam, look for deformity, callus, blister, linear crack or fissure. Check the toe webs because there may be a crack or fissure. Look on the dorsal surface, look at the nail folds for any thickening or ingrown nail folds. Then feel or palpate dorsalis pedis posterior tibial pulse. Do you feel this?
yes,
Using the monofilament, tell me when you feel it.
yes, 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 yes.
2 negatives, we need 4 or more negatives for a positive test. Remember to do the other foot.
So it's a good idea to have these type of screening tools in your facilities, just to make sure that we are looking at diabetic feet in a proper manner. We've talked about pressure on the foot and we've talked about the Charcot foot. So the management of offloading is by means of different type of devices that can be used in different ways. One of the most important things that patients have to undergo when they are going to a diabetic foot clinic is checking the plantar pressure. One of the most common ways how to do this is to have a rubber mat which is connected to a computer. The patients walk on it and then it gives us that pressure mapping that we see. There are loads of different devices nowadays. We have insoles, we have socks, we have a lot of things that can do pressure mapping. What is most important is to understand that in line with those results, we can have the proper way of how to do diagnosis. So the main aim of offloading is to redistribute those pressures. So if you don't have any disease, when you walk, the pressure that you do on your foot is all over. But in these type of patients who have diabetic foot disease, they can have areas, as you see at the bottom left-hand corner, of exaggerated pressures in area which will lead to callus formation and eventually ulcers. These are type of removable offloading devices. They can be according to the diagnosis of what is happening on the foot. Usually it's the podiatrists who are specialized here, and we also have non-removable offloading. One of the gold standards, especially when it comes to Charcot foot management, is by means of a total contact casts. So the podiatrists have these type of knowledge, maybe helped even by this type of charts of what type of problems that the patients have, what type of offloading needs to be done. Remember that prescribing an offloading device is a specialized area. These are the podiatrists, so it's very, very important that these patients are referred, as I said in the very beginning, at least once a year to these specialized centers. What we do know is that offloading is not in many patients. Most of the patients who should have offloading don't have it. If they don't have offloading, the problems will be even more. Only a very minor part of these patients do get offloading. There's a lot of excuses why we don't do it. However, it's very, very important to understand that these patients do need offloading when needed. We're going to look at a patient video now, but it's always good to learn with our patients.
The purpose of this video is to help you understand the importance of offloading, the use of special footwear, and helping your foot ulcer heal as quickly as possible. Healing quickly can reduce your risk of developing serious complications. Key elements for successful healing are rest, eat a balanced diet and maintain your blood sugars in a controlled range, wear the device your doctor tells you to wear at all times, and refraining from smoking. Foot ulcers need rest in order to heal. If you were to break your leg, your doctor would tell you not to walk on it. It is the same with your foot ulcer. We rest ulcers by taking off the load, or offloading the ulcer using special casts, boots, or shoes. The possible complications from a foot ulcer that fails to heal are development of an infection, infection spreading to the rest of the body resulting in hospitalization, amputation of the foot or leg, or even death. Foot ulcers put you at considerable risk for amputation. Amputation of part of your foot or leg can lead to changes in your ability to do activities that are part of your everyday life. It can lead to a decrease in activity, which can weaken your heart and body, making it difficult to control your diabetes. It can also change the way you walk or move, potentially causing damage to your other foot and leg. Most importantly, the challenge of having an amputation can lead to depression and sadness, affecting how you are able to enjoy your family, friends, and hobbies. Normally, your body's response to pain is a sharp reflex that allows you to recoil and prevent further injury. Diabetes causes changes to the nerves in your feet and the ability to feel or sense pain. It robs your body of the protective gift of pain, or the ability to protect itself. This condition is called neuropathy. People with neuropathy can walk with a stone in their shoe and not notice it. This could cause an ulcer or blister on their foot. A person with neuropathy does not know that they have a sore or blister on their foot because they cannot feel it. By the time you notice the ulcer, it can become very serious. This is why it is important to check your feet every day for problems. Diabetes can cause the skin on your feet to become very dry, creating cracks that later become sores or infected. Ask your doctor to recommend a good moisturizer for your feet and heels. People with diabetes can also have changes in their leg and foot circulation. This reduces the oxygen, nutrients, and blood supply to your leg, increasing your risk of getting an ulcer and slowing your ability to heal. Your doctor may order a test to examine your circulation. Because of these factors, simple everyday activities such as walking or standing on your injured foot can be harmful to your healing ulcer. It could worsen the condition or cause infection. If you smoke, it is important that you talk to your doctor about treatments to stop smoking. Smoking is a large reason why people develop circulation problems in their legs and feet. Continuing smoking will slow healing to your ulcer and likely make your circulation worse. The best way to heal your diabetic ulcer is to take off the load by using special casts, boots, or shoes. It is important to wear these all the time, even if you are only taking a few steps. The best way to heal a diabetic foot ulcer is to use a special cast called a total contact cast. Research shows that more people treated with total contact casts heal than with other treatments. These include bioengineered tissues, such as growth factors or synthetic skin substitutes, and negative pressure wound therapy. They also heal faster than with many other of the newer advanced wound healing technologies. People treated with total contact cast heal in an average of 42 days.
So next I'm going to make this irremovable by adding on a layer of cohesive bandage.
Your doctor can also adapt your diabetic walking boot so that you cannot take it off. This has been shown to be just as effective as a total contact cast. Your doctor may use a combination of wound and offloading treatments to best heal your ulcer. It may be scary to think of your ulcer being in a cast where you can't see it, but the cast helps even out your weight so the pressure is not just on one part of your foot. Your doctor will change the cast every few days and even up to once a week if your ulcer is healing well. When a person breaks their leg, they don't tell the doctor that the cast is awkward or ugly and ask for another way to heal their leg.
Sorry about that. So we've seen an idea of what offloading is. One thing that we need to keep in mind that when it comes to the Charcot foot, nowadays there are specialized orthopedic surgeons that can treat it, but only we usually go to that part when the conventional management like offloading doesn't work. So remember, diabetic foot care is a standard of care, making sure that we provide the proper offloading, making sure that we are using proper ischemic control. So we refer the patients to the x-rays or interventions that will show us. If we have an infection, we make sure that we treat it properly. Remember, osteomyelitis is another huge problem in diabetic foot. Debridement of the wound, but also debridement of the calluses and proper local wound care according to international guidelines. So if we look at the IWGDF, they give us very good guidelines of what to use and not what to use. For example, they are suggesting that if we use negative pressure, this is only done post-operatively. One of the emerging and most popular dressings that we use nowadays when it comes to diabetic foot ulcer management is by means of a TLC and OSF dressing that controls the levels of MMPs. The IWGDF also tells us what it suggests not to use. I suggest to you to go on the IWGDF website and you can download these guidelines and refer to them when you ever need them. Do we have any questions or comments regarding the diabetic foot? It seems not, so we will move on to the last session for today, which is leg ulcers. Starting off with a question, if we're talking about a venous leg ulcer, how long do you think is the average time of healing? 20, 120, or 110 days? Give you about 10 more seconds. So those of you who have answered the poll think that 210 days is actually quite a long time. Well, unfortunately, the correct answer to that is 210 days. Despite the best services that we give these patients, these wounds take a long, long time to heal.
The idea of this video is to tell a brief story of my issues and maybe highlight to those people that are experiencing similar issues.
You are never unaware of having a leg ulcer.
So if we're going out, I would never be the one wearing a dress or whatever. I'd wear trousers or a long skirt or a long dress. Thank goodness the maxi dress is coming into fashion.
You can't get up in the morning and spontaneously jump in the shower without putting your leg in a plastic bag or something.
It was very painful. It wasn't a small pain. I couldn't see anybody. I couldn't walk.
I went from having a patch that was the size of a 10-pence piece, to having a whole bottom of my leg that was no skin.
It's meant that I've not been able to have a full-time job. I've not been able to follow the career that I wanted to do.
So I have other issues as well, which we wonder possibly maybe if it's to do with the lipedema or is one causing the other. It's very hard to know.
Well, I actually got back in treatment March the 4th this year, and it has been life-changing.
It's been a lot better since I got the diagnosis. Since I was diagnosed and I actually knew what I was dealing with, it's really helped.
It will never be healed because obviously I've got permanent damage to the veins in my legs, so I need to wear some rather fine support hosiery, but by crikey, could it work?
To someone that has got it, don't let it rule your life.
And I'm pleased to say over the last few weeks that it's finally healed.
But you must get treatment.
I would say get the right advice and help.
Just to be in treatment is life-changing. That's 2 words.
Mentally, I don't think I can put into words how much it means to me to possibly see the back of this.
They should be positive.
I am really hoping that the Legs Matter campaign can spread the word even more.
So I hope that Legs Matter reaches out to all those people and gets them the right advice right from the very beginning.
So that's a very good thing to look at. Go to the legsmatter.org website, which is very supportive of our patients living with leg problems. And as you've seen, it's not just old people, but even younger people, which brings us to the reoccurrence. How often do you think the percentage of video use that reoccur? So again, the answer to that is that these leg ulcers unfortunately do occur a lot. They occur in about 70% of these patients because unfortunately, once we think that a venous leg ulcer is healed, they stop using any type of compression and it will come back again. If we're looking at reducing healing time, it's the most important part of this treatment, because if you reduce healing time, you're managing costs, you're reducing complexity and making the patient's lives a lot better. So reduce that healing time as much as possible, and we'll see that the standard of care of a VLU is not that complicated, and we can give the proper treatment to our patients to manage to get them back in their life as quickly as possible. So if you think that your patients are not receiving the best treatment, which is supported by the best evidence that we have, make sure that we look at it and we'll start doing it.
Leg ulcers are common. Approximately 2% of adults will have a leg ulcer at some stage in their lives. Literally thousands of people develop a leg ulcer each year in the United Kingdom, and many of those get more leg ulcers as the years go by. Despite the misery they cause, leg ulcers remain a neglected problem. I'm going to tell you the 7 essential facts you should know about leg ulcers. Number 1, what is an ulcer? The medical definition of an ulcer is a break in the epithelium of a body surface or lining. Many of us will be familiar with a mouth ulcer. This is a break in the cell lining of the mouth. It can be caused by an injury, such as biting the inside of the mouth by accident. Well, if the skin breaks down anywhere on the body, it is called an ulcer. If the ulcer is on the leg and has been present for more than 6 weeks, it is called a chronic leg ulcer. Number 2, what causes a leg ulcer? 4 out of 5 ulcers, that's 80%, are caused by a problem with the leg vein pump, and they are called venous ulcers. The leg vein pump is the mechanism by which blood flows out of the leg back to the heart. So problems with the deep veins, such as obstruction from deep vein thrombosis, superficial vein reflux, or perforator vein problems can cause venous leg ulcers. The leg vein pump depends mainly on good ankle movement, good calf muscles, and healthy leg veins. A minority of leg ulcers, about 15%, are caused by problems in the arteries that carry blood into the leg. About 95% of venous leg ulcers can be correctly identified by their appearance, by checking for pulses in the feet, and by checking sensation. As most leg ulcers are venous, that's what I'm going to concentrate on. Number 3, where on the leg do you get venous ulcers? Well, venous leg ulcers appear on the lower part of the leg, usually just above the ankle. Often there are varicose veins or thread veins around the ulcer, and the leg is usually swollen. The skin is often thickened and discoloured by varicose eczema, which may actually develop many months or years before the ulcer as a warning sign that the vein circulation is not normal. Number 4, who gets a venous ulcer? Well, these ulcers affect people who have deep vein problems, usually from a past deep vein thrombosis, people who have superficial venous disease, or those with ankle mobility problems. Leg ulcers are more common as we get older. Number 5, how do you treat venous ulcers? The aim of treatment is to get the ulcer healed as quickly as possible. This usually means graduated compression, either with bandages or compression stockings. In most cases, Antibiotics, creams and ointments are not necessary. Once the ulcer is healed, it is very important to identify any problems with the superficial veins or the perforator veins, and that these are treated to reduce the risk of another ulcer. This means getting a full assessment with a duplex ultrasound scan. Number 6, can you cure a leg ulcer? Well, this is controversial. Some would say that if the problem is only in the superficial veins, the veins under the skin, or in the perforator veins that connect these superficial veins to the deep veins, then the ulcer can be cured. While there is good evidence that such treatment will greatly reduce the risks of getting another leg ulcer, if the skin has been very damaged and the ulcer has healed with a lot of scarring, this area of the leg may remain vulnerable, and a trivial knock or an injury might cause another skin breakdown, even though the vein abnormality has been completely eradicated. Number 7, how can we avoid leg ulcers? Well, there are 3 things I would suggest. Firstly, if you are unfortunate enough to suffer a deep vein thrombosis, it should be treated promptly to limit the damage to the deep veins. Unfortunately, damage to the deep veins cannot be reliably reversed by surgery. So, prompt treatment with anticoagulants, blood thinning medication, reduces the extent of the clot and the damage to the deep veins. Secondly, if you have had a DVT, you should consider wearing good quality medical grade compression socks. Some studies suggest that doing so may reduce the risks of leg ulcers after a big DVT. Thirdly, if you have superficial vein reflux, have it treated early to reduce the chances of progression to varicose eczema, which is itself a warning sign that the skin is damaged and liable to ulceration. Now, I hope you found this useful. Don't forget to subscribe.
So, just as a reminder, it was already mentioned, we have the arterial circulation to the leg and the venous circulation of the leg that provides the body, the lower leg, with the blood that we need, and then the venous system will repel the blood back up towards the heart. One very important part of veins are the valves, which do not allow the reflux of the blood back towards the gravity. Again, just a reminder of the simple, very simple anatomy of the leg, where we have the deep veins, the superficial veins, and the perforator veins. The deeper the problem, the more complicated it is. So what happens because of different disease processes? These valves can become damaged, and once they are damaged, then we have chronic venous insufficiency. The doctor already mentioned it in his video, but just to see if you remember it, which is the most important muscle when it comes to venous return. This is the abdominal, calf, both, or depends. Give you a few more seconds. So, as was said in the video, the calf muscle pump is very important when it comes to the venous return, because the contraction and relaxation of the muscle presses on the veins to propel the blood up, opening the valves up. When it relaxes, the valves come back in place and occlude and doesn't allow the blood to regurgitate back. So that venous return is very, very important. So this makes us remember that if there's a problem with the scalp muscle, patients are more at risk for chronic venous insufficiency.
Besides the venous valves, the so-called muscle pump also plays an important role in transporting blood against the pull of gravity. The large veins in the leg are surrounded by muscles that tense and thicken when we walk. This muscle action presses on the veins and pumps the blood upwards. When the muscles relax again, the venous valves prevent the blood from flowing backwards, as described above.
So the valve malfunction is usually acquired, very rarely congenital, and this happens when the calf muscle cannot work because of different problems, but also the main causes of chronic venous insufficiency comes with that high pressure, which can be caused again by immobility and by heaviness of the patients. So as we said, chronic venous insufficiency and venous leg ulcers is one of the predominant causes of leg ulcers. There's usually a history of obesity, positivities, and anything to do with poor mobility occurs in the lower 1/3, and we'll go also more in depth about the conditions that can predispose. And the changes in the lower leg are indicative, even very, very early, of what is going on. Because if you look at these stages of problems with the lower leg, spider veins, varicose veins, leg edema, and skin changes, many people associate this with old age. This is actually a sign that there is something wrong with the venous return of the blood. This is the CEP classification, which is internationally known. So make sure that when we are checking, doing the skin assessment of our patients, look out for these very subtle telltale signs that can tell you that the patient has got problems with their veins, and therefore you need to refer to a vascular surgeon. Other type of characteristics in the beginning, but also later on, these are very common in patients with chronic venous insufficiency. We have many areas like the dermatitis, the lipodermatosclerosis, and the hemosiderin deposition makes the skin more easy to be damaged because it has lost its elasticity. So these patients' legs need to be treated like fine bone china, because once there is a crack, you cannot fix it anymore, and the recurrency is quite huge.
Our blood vessels transport about 7,000 litres of blood every day. The veins in our legs carry blood from the lower extremities against gravity back towards the heart. The two most important mechanisms in this process are the calf muscle pump and the venous valves. During walking and exercising, our calf muscles repeatedly contract and relax. When they contract, they squeeze our veins. This pressure allows blood to flow upwards, thereby opening the venous valves. When inactive, the calf muscles relax, and the blood starts to flow backwards, thus causing the valves to close tightly and preventing further blood from flowing back to the feet. When veins become insufficient, however, they dilate and prevent the valves from closing properly. This in turn causes a reflux, which is when the blood leaks downwards and stagnates in the vein. If left untreated, this can result in the appearance of venous disease. Symptoms of venous disease vary depending on severity and may include itching, swelling, cramps, pain, and legs that feel restless or heavy. Meanwhile, visible varicose veins can also develop. Untreated varicose veins can cause inflammation of the venous wall and surrounding tissue, followed by the appearance of edema. Furthermore, blood cells can leak out of the vein into the surrounding tissue. This results in hyperpigmentation of the skin. The most severe form of untreated varicose veins is an ulcer. The major risk factor for venous disease is genetic predisposition, combined with other factors such as prolonged sitting or standing, obesity, advanced age, or pregnancy.
How do we manage venous leg ulcers? Do you think it's by means of compressions and dressings, or surgery? Jonathan? Jonathan, can we share the poll, please? Okay, we might as well skip that. Don't worry. So the standard of care for venous insufficiency and the ensuing ulcers is by means of using proper compression and using dressings that will reduce the matrix metalloproteinases. So what compression does is that it presses those interstitial fluids back into the circulation, but also compresses the veins so that the valves will start working again. Even after the patient's venous leg ulcer has been healed, it's very important that graduated compression continues. And then even after those 3 months, instead of the bandages, we can use hosieries, so always preventing problems. And this is a very easy diagram to see how that compression bandaging will assist into bringing back to as much as possible to normality the situation that we have. So compression therapy is usually by means of multi-layer or multi-component bandages that have to go up to 40 millimeters of mercury according to the results of the ankle brachial pressure
Understanding
index.
compression therapy for venous and mixed leg ulcers. Venous leg ulcers are the final stage of venous insufficiency, occurring as a result of impaired venous dynamics and increased pressure in the veins. Continuous compression around 40 millimeters of mercury at the ankle on average is the treatment recommended to restore venous dynamics and effectively heal venous leg ulcers. However, effective consistent compression can be difficult to achieve in daily practice, causing delayed healing and impaired quality of life for the patient. There are many types of bandages available. Bandages can be made of elastic material, in which case they're called long stretch bandages, or made of inelastic or low elasticity material, in which case they are called short stretch bandages. Long stretch bandages maintain a constant pressure by continuously squeezing the muscle, whether the muscle pump is activated or not. The disadvantage is that if used alone, they exert a high resting pressure that patients may find uncomfortable, leading to concordance issues. Short stretch bandages have a low resting pressure and a high working pressure. They have a high stiffness index. When walking, leg muscles are held tight by the bandage, providing a massage effect that improves venous dynamics. The disadvantage is that if the calf muscle pump is weak or ineffective, short stretch bandages fail to deliver adequate levels of compression. When used alone, short stretch bandages tend to rapidly lose pressure and slip down the leg, with a risk of trauma to the skin. Both types of bandages can be applied one over the other to create a multi-component bandage that combines the advantages of long stretch and short stretch bandages to provide continuous compression. International guidelines recommend multi-component bandages first line as the most effective in healing leg ulcers.
So it's very important to remember this, that multi-component bandages are the best. So the use of those tubular bandages or whatever you call them is not effective at all in chronic venous insufficiency. They are just burdening the patients and not doing any work. There are multi-layer systems where you have, for example, a foam and then just a bandage on top of it. That means that you only have one bandage. And if you have only long stretch or short stretch, we know it doesn't work. You need to have a multi-component system that combines both the long stretch and the short stretch. It's called graduated compression because it starts, according to the Laplace law, 100% at the angle, and then it gradually reduces. Okay, we can do away with that. The important thing is also to get the compression correct, and that is why not all the bandages are correct for chronic venous insufficiency. You need to make sure that you are using a system that can give you the exact amount of compression. One easy way to understand what compression needs to be done, or if we should do any compression, is by means of doing the ABPI.
Good morning. We're here today to talk about the process of doing an ankle brachial index. You would do an ankle brachial index to establish the quality of arterial flow, especially in patients who have lower extremity wounds and who you are thinking about using compression on as a treatment. The setting today is an outpatient wound clinic, so part of our normal new patient workup for patients with lower extremity wounds is to do an ankle brachial index. So today we're going to demonstrate the process of obtaining that. Now also remember that if the patient is a diabetic, an ABI can be falsely high, but we'll talk about that after we get the results of this test. First of all, you put the manual blood pressure cuff on the patient's arm on the side that the wound is. And then you just use the stethoscope and manually obtain this blood pressure, the systolic blood pressure. So then you take the blood pressure cuff and you wrap it around the ankle. And if you have a wound on the ankle, you just, it's fine to do it on top of that. You just cover the wound with a sterile gauze and then try to wipe the cuff off after that. Prior to inflating the cuff, you want to use your Doppler and locate the dorsalis pedis pulse. And then you inflate the blood pressure cuff to the point where you obliterate the sound, and then the first sound you hear is your ankle pressure. So then, if you don't have a chart, you just divide the ankle pressure by the brachial pressure to get your result, a normal result being 1.0.
So when it comes to the interpretation of the ABPI, there are different ones with slight derivations, but mostly we are talking about having the same. And what can help you is to find cheat sheets which can be downloaded from the internet to tell you what is going on with the result of the ABPI. And remember, with diabetic patients, it will give you a false high because of the calcification. So with diabetic patients, the toe index is a lot more indicative. So the types of system in the old days, we used to do a 4-layer bandage, which takes quite a lot of time to put in place. It's very, very uncomfortable for the patients, and they will remove it very, very easily. And the problem is that we don't know how much pressure we are applying, and you can get either above or below the therapeutic index of 40 millimeters of mercury. Newer systems have both the long stretch and the short stretch bandages, and they will have indicators on them which tells us how much to stretch and to overlap to get the correct therapeutic pressure. Compression hosiery is also quite common. Remember, these have to be medical grade hosieries. This is the British tariff, where we have 3 classes. We have the class 1, which is the light bandaging that can be used even for traveling or for people who are standing up quite a lot, or people who are sitting down quite a lot, or have any other predisposing factors like patients who have had a lot of pregnancy. The class 2 is usually used as prevention for patients who either already have had an ulcer which is now healed, but also we can have the high levels of pressure, which, although they are quite good, they are very, very difficult and painful for the patient to apply. And we know that actually graduated compression works better than hosiery.
Peripheral arterial disease, or PAD, refers to blockages in arteries that are away from the heart. These blockages are typically fatty buildup or atherosclerosis, the same process that can involve a blockage in a heart artery. When we hear the term PAD, it is generally thought of as referring to lower extremity PAD, which involves blockages in the arteries in the leg.
So one of the first signs and symptoms of ischemia in the lower limb is intermittent claudication. So basically you have the patients that report that when they start walking, they have to stop because they have cramps in their calf muscle, and this indicative that the circulation is lacking in the lower leg. Arterial ulcers can be found anywhere in the lower leg after trauma. They look very similar. They're usually very round, punched out appearance. But also, if there is microangiopathy, we can have gangrene of the toes. So there are different types of invasive and non-invasive investigations that can be done. Obviously, referral to a vascular surgeon is really important. If we look at the different management, remember that with venous ulcers, we need to use the graduated compression, while with arterial ulcers, we don't use compression at all. We have to make sure that the lifestyle choices are changed, and the vascular surgery is many times needed for revascularization. So it's very important to understand the different signs and symptoms of venous leg ulcers and arterial ulcers. So we'll show you now the last 2 short videos about the characteristics of venous ulcers and arterial ulcers.
In order to facilitate identification of ulcer similarities and differences, typical characteristics of various types of ulcers will be described using the 5PT method. This includes pain, position, presentation, periwound, pulses, and temperature. Individuals with arterial insufficiency ulcers commonly report severe pain. This pain is caused by tissue ischemia. The pain may worsen during activities that increase tissue metabolism, such as ambulation. Positions that further compromise tissue perfusion, such as leg elevation, may also cause an increase in pain. Individuals with arterial insufficiency often report difficulty sleeping due to leg or foot pain. Generally speaking, patients with rest pain have more severe occlusive disease than those with intermittent claudication. However, it is important to note that the pain of arterial insufficiency may be masked in individuals with diabetic neuropathy, and the absence of claudication pain does not rule out arterial insufficiency. Arterial ulcers are almost always located in the lower extremities because of the increased distance blood must travel to reach those areas. Arterial insufficiency ulcers are commonly located on the toes, either dorsally or distally. Trauma is a leading precipitating factor in arterial ulcer development, so potential causes of trauma should be assessed for ulcers located in unusual positions. Arterial ulcers generally begin as small, shallow wounds that gradually increase in size and depth. Ulcers are normally round and regular in appearance or conform to precipitating trauma. Granulation tissue, if present, is pale or gray because of decreased oxygen supply. Necrotic tissue is generally desiccated black eschar, but may be yellow if the wound is bandaged in a way that maintains tissue hydration. Gangrene may be present with more advanced disease. Because of diminished circulation, there is minimal or no wound drainage, even in the presence of infection, and only minimal bleeding with wound debridement. Patients with chronic arterial insufficiency ulcers usually show signs of decreased perfusion. When blood supply distal to the occlusion becomes inadequate, many changes occur. The epidermis becomes thinner, shiny, and dry, and there is loss of hair growth. Poor tissue oxygenation increases the risk of fungal infections, making nails yellow, thickened, and brittle. Prolonged severe ischemia may cause muscle atrophy. Color changes may be evident, with the affected limb appearing pale, dusky, or cyanotic in color, especially with elevation. The limb may have dependent rubor. Edema is unusual with arterial insufficiency, but if present, may represent concomitant venous insufficiency or congestive heart failure. Patients with arterial insufficiency may try to reduce ischemic pain with prolonged dependent positioning, which can result in minimal edema or exacerbate coexisting venous insufficiency. Pulses at the dorsalis pedis artery and the posterior tibial artery are likely decreased or absent in the case of lower extremity arterial insufficiency. In severe cases, popliteal artery and femoral artery pulses may also be altered. If pulses are not readily palpable, more sensitive measures of circulation testing, such as a Doppler ultrasound, ABI, or toe pressure measurements, should be performed. Ischemic digits or limbs will be cool or cold to the touch because of decreased blood supply. Since the dorsum of the hand is more sensitive to temperature changes than the fingertips, skin surface temperature can easily be assessed by lightly palpating with the back of the hand after allowing the patient to rest supine with shoes and socks removed for at least 5 minutes prior to testing. The temperature of the patient's foot should be compared with more proximal body areas. To facilitate identification of ulcer similarities and differences, typical characteristics of venous ulcers are described using the 5PT method: pain, position, presentation, periwound, pulses, and temperature. Individuals with venous insufficiency and venous insufficiency ulcers commonly complain of dull, aching leg pain or heaviness. The cause of this pain is venous hypertension and the resulting peripheral edema. The pain is usually increased with dependency and relieved by elevation or compression. Patients typically report a decrease in pain both at night due to a decrease in gravity while in bed and first thing in the morning due to edema reduction overnight. Many patients report increasing leg heaviness and aching as the day progresses. This results from prolonged dependent positioning such as sitting or standing. Pain may be severe in the presence of infection or coexisting arterial insufficiency. Patients with diabetic neuropathy are unlikely to complain of pain associated with their wounds because they have decreased sensation. Venous insufficiency ulcers are usually located on the medial aspect of the lower leg or medial malleolus. It is also common to find venous ulcers in areas exposed to trauma, such as the anterior shin. Venous ulcerations do not occur on the plantar aspect of the foot and rarely occur above the knee. Venous insufficiency ulcers are generally superficial, irregular in shape, and have moderate to high amounts of drainage. If the dressing does not absorb enough wound drainage, the wound edges will be white and fragile due to maceration. The wound bed contains beefy red granulation tissue, but may take on a ruddy appearance. A thin yellow fibrous coating may cover the wound bed, giving it a glossy look. Venous insufficiency is often associated with many skin changes. Cellulitis, dermatitis, and dry scaling skin, which may cause intense itching, are common. Superficial varicosities and evidence of previous ulceration may be present. Lower extremity edema is usually always present. In cases of long-standing venous insufficiency, the edema may become firm or indurated. Initially, skin changes may include a subtle erythema. With chronic venous insufficiency, the skin becomes stained and more darkly pigmented due to hemosiderin deposition. Hemosiderin is a byproduct of the breakdown of red blood cells, which have been forced into the interstitium by venous hypertension. The term lipodermatosclerosis is used to describe the hyperpigmentation and accompanying erythema, induration, and plaque-like structural changes that occur due to long-standing venous insufficiency. The skin and subcutaneous tissues are more fibrotic and less elastic than healthy tissue. Pedal pulses are generally present and normal in patients with venous ulcers. However, peripheral edema resulting from venous insufficiency may make pedal pulses difficult to palpate. In addition, it is not unusual to have coexisting arterial disease, which may decrease pedal pulses. If pulses are not normal, an ABI should be performed to assess for arterial insufficiency. It is not uncommon for cellulitis or edema from venous hypertension to cause a mild increase in the affected extremity's skin temperature. Local warmth may also be the result of ulcer infection.
So, apart from having purely venous and purely arterial, we can have mixed arterial and venous leg ulcers, which have a combination of both the diseases. So it's very important here to understand which is the most predominant and treat mostly the predominant cause. Remember that if we're going to use any compression in these patients, we don't apply the full 40 millimeters of mercury, but we apply a reduced compression at 20 millimeters. Leg ulcers are not just venous and arterial, although they are the most common. Unfortunately, we can have also skin cancers, which are usually more common in areas which are exposed to the sun, but we do have skin cancers that occur in the lower leg. One of these type of malignant tumors that can be found on the leg is called the managerial ulcer, which is a common type of tumor associated with these type of ulcers with a squamous cell carcinoma. Many times this appears over skin diseases such as chronic ulcers, but it's quite common, unfortunately, in patients with burn scars as well. The marginal ulcer is an ulcer which is caused with hypertension, and you can find in patients which don't have any problems with circulation, either arterial or venous, but have long-standing hypertension. These are very, very painful wounds. So when it comes to management, the management is taking care of the hypertension, taking care of the pain management. Sometimes compression therapy is applied to help, especially if there is lower limb edema. Another rare but not that uncommon is pyoderma gangrenosum, which is an autoimmune type of ulcer that can happen. These appear usually as very small pustulae or blood-filled blisters, but progress very, very quickly, become very painful. Although there is no test to do it, the Persolus test can help us try to evaluate if PG is likely or unlikely. The PG is the most common type, is the ulcerative type, which appears on the lower limb. One of the most common features is that hue of purplish tissue around the limb, but it can happen in other areas. And talking about bullae as well, we talk about bullous peregrinoid in a couple of slides. So this is an autoimmune disease, so the treatment, usually you have to refer these patients to dermatology, and the use of corticosteroids is there, but also obviously the management of the wound according to the wound bed preparation. The bullous peregrinoid is another rare disease, which unfortunately we see in our days. It's most common in adults between 60, 70s or more, where these patients have these type of hypersensitivity reaction, where they have these bullae which rupture and leave a scab, which can become an ulcer. We don't know exactly what happens, but it could be because of exposure to ultraviolet and radiation therapy, and the result may be of certain drugs. So these blisters can occur anywhere in the body. Most commonly, they appear on the lower legs. So again, this is a dermatological problem, so we have to refer to dermatology. The use of topical corticosteroids is very, very common. And when you're using any dressings, remember to use non-adherent dressings so that you don't cause any further damage when you remove them. So that brings us to the last part of today's session. So if there are any questions or comments, please. Anything to add, anybody? So I think that's the end of the session. If you have any questions that you want to forward to us through email, please do so. Jonathan will share them with me.
Yep. Okay. Okay, if we're all good, thank you everyone for coming. Thank you, Emilio, for sharing today.
Always my pleasure.
Thank you very much. Okay, for you, have a good morning ahead, and for the rest of us, have a good dinner. Thank you. Bye.
Thank you. Bye-bye.